welcome back to another episode of Coffee with Coker. My name's Mark Reibel, and I'm the host of the podcast. And in case you're new to the podcast or you're unfamiliar with what we're talking about here, Coffee with Coker is a healthcare business podcast. It's published by the Coker Group, and we talk about solutions that help healthcare organizations navigate the changing healthcare industry. And with that, we are excited for another episode. And joining me today, I have two guests, actually, and I'm very excited to have both of them contribute to this topic. One of those is a guest that you all may be familiar with. It's our Chief Medical Officer, Dr. Mac Knight. He's been on a few episodes with us. And we also have a newest member, I guess, of the Coker Senior Management Team, Brandt Jewell, who's over physician enterprise. And today we're talking with Brandt and Mac about MACRA. And specifically, we're talking about getting prepared, how organizations can get prepared for MACRA, which is really here, but it really starts to become meaningful as of January 1st, 2019. So it's absolutely something that's on the radar. We know for all healthcare organizations out there, particularly your hospitals and health systems. Some, though, are a little bit further down the path, more so than others, as it relates to how they are preparing or how prepared they are, I guess, for the provisions that will come with MACRA. And so in this discussion, Brandt and Mac talk about what MACRA is, why it's meaningful, why it's relevant, and at a high level at least. And then we jump into what are some of the key components that are most relevant, or at least some of the key areas where we know change is coming as a result of MACRA. And I think, it's also something where this discussion tees up what we'll continue to talk about, and we'll have future episodes on as it relates to kind of more specific areas of action or response that we've seen organizations, or we're recommending for organizations to consider as they are either preparing or diving straight into compliance as it relates to MACRA. Also want to mention that I want to encourage you all to stay tuned, or if necessary, skip about halfway through towards the end of the episode. We go kind of from the high level or conceptual level discussion to talking about what I would say are some of the more actionable recommendations that Brandt and Mac discuss, and that we're able to kind of put out there as considerations for your organization as you're thinking about preparing for MACRA. So there is kind of that conceptual level discussion, but there's also specific, a little bit more tangible recommendations that I think are relevant here and hopefully are of some value. So we hope you enjoy. As always, we want to recommend your feedback and participation. So you can find all of our episodes if you're interested. You can find all the episodes of the podcast at coffeewithcoker.com. And you can provide feedback for us, whether it's questions or recommendations for future topics to discuss or guests to have on the show. You can reach out to us at feedback@cokergroup.com, or again, you can reach out to us through the website at coffeewithcoker.com. So I hope you enjoy this discussion with Dr. Mac Knight and Brandt Jewell on getting prepared for MACRA. All right, welcome back to another episode of Coffee with Coker, and we're going to jump right into our topic today. And this time, we are talking about MACRA, being prepared for MACRA, which is coming, which really is here. We'll talk about that, and I'm excited to have two guests with us actually today. And as was mentioned in the introduction, of course, many of you will be familiar with one of the guests who's kind of a frequent here lately, I guess, on the last few episodes, but Dr. Mac Knight, who is the Chief Medical Officer here at Coker. And, of course, he covers a lot in that role in terms of what we do, but he is definitely the resident expert as it relates to MACRA and all things value-based healthcare here. And then also Brandt Jewell, who also was highlighted on another recent episode where Brandt's actually new to the Coker team, but has a long, impressive track record working with healthcare provider organizations, whether they be hospitals, health systems, medical groups, etc., on a wide range of things, but specifically with experience in MACRA and in the realm of value-based healthcare as well. So I wanted to talk with Mac and Brandt today just to dig a little bit deeper, as we have in past episodes talked about value-based care and what that means at a high level, as well as some of the different components of it. And today I really want to drill down into MACRA, which is something that again is really here today. So Mac, Brandt, welcome.
Thank you.
Yeah. So let's dive right in, I guess, with the discussion. And again, as was kind of referenced in the intro, and we'll make it available in the show notes, this is a lot of the discussion we're talking about today is actually content related to a white paper, Mac, that I know you developed recently, and you've written a number of things, articles and papers on MACRA, MIPS, and alternative payment models, et cetera. And so a lot of what we're talking about ties into that paper. But, I thought it'd be helpful to go through, I think, in terms of where to start, though, whether you're familiar with what MACRA is at a high level or not, I feel like we need to cover that basis. So maybe just give us the quick rundown in terms of the introduction to MACRA.
Sure. So being the namesake of MACRA, I guess you could say that
you couldn't let that one slide, right? You had to do that one.
Should have quite a bit of knowledge about this. But in all seriousness, MACRA, is probably most everybody knows, stands for the Medicare Access and Chip Reauthorization Act, which was passed back in 2015 and actually will go into full effect with either increases or decreases in provider reimbursements in January of 2019. So it's been around for a while, slowly being rolled out. Reporting started in 2017. And again, the effect of that reporting on reimbursements will happen next year. There's a 2-year lag. But rather than kind of get into the arcane nature of this legislation and all the rules and definitions, which many of you are probably already familiar with, I think it's important to think of MACRA as the biggest pay-for-performance, value-based reimbursement program that we've seen to date. Obviously, Medicare is the granddaddy, the big kahuna of all payers. And when Medicare comes out with a pay-for-performance plan for Medicare providers, that's a big deal. So we are about to see, certainly in my professional lifetime, one of the biggest changes in the way providers, physicians, and other providers in the Medicare program are paid. And again, that's a very big deal, and I look forward to discussing some of the ramifications with you today.
One of the things when we're talking about MACRA, I'm glad you kind of mentioned somewhat of the background and the evolution of it going back to 2015. One of the things that's gone kind of hand in hand with MACRA itself is this other piece of legislation or other component, other provision, I guess, that we call MIPS. And then there's kind of other things that have spawned out of that as well, one of those being alternative payment models. So maybe talk real quick about where MIPS fits in, because that's kind of its own unique element, obviously. And then APMs obviously have their own role in this overall discussion as well.
Sure. So MACRA itself it was, again, a piece of legislation. But that legislation called for two fairly distinct payment programs. First is the Merit Incentive Payment System, which is MIPS, and that has to do with, again, measuring performance across actually 4 categories: quality, cost efficiency or resource use, clinical practice improvement activities, and then what used to be called meaningful use and is now called advancing care information, and using performance of individual providers or groups of providers on those 4 categories or within those 4 categories to base payments or at least adjustments in payments. The second payment program is alternative payment models. And for those of you that want to know what the most common form of an APM is, it's an accountable care organization. Mm-hmm. So the ACA, the Affordable Care Act back in 2010, introduced Medicare ACOs. Those have evolved too over the last 8 years, but now there are several types of ACOs or Medicare shared savings programs that count as alternative payment models under the MACRA legislation. So if you're a single provider group or a single provider out there and you are obligated to participate in MACRA, you've really got the first big choice to make, and that is, do I do that through MIPS or do I do that through an alternative payment model such as joining an ACO or a specialty medical home or some of the other types of APMs?
Yeah, which is interesting because that brings up a lot of kind of alternatives in terms of thinking about planning for the future. If you're a group or even, a small practice, you're obviously have to think about, okay, where do I fit in with all of this? And then on the other side, on the hospital side, how do we offer something? How do we construct something that allows our providers in our community to, whether it's through other alignment models or existing ACO, which are now somewhat commonplace, but other value-based initiatives.
Yeah, it might be interesting, not to take over the narration role here, Mark,
Please.
But to ask my new Coker colleague, and Brandt, we're very glad to have you at Coker now, who's really probably been closer to physician practices and the management of same than I have, even though I'm a physician. It's been a while since I was in a physician group. But Brandt has recently had a lot of relationships and does a lot of work with physician groups. How aware do you think, Brandt, most groups are of this, and which way do you see them going in that kind of initial choice of APM or MIPS?
Yeah, thanks, Mac. I appreciate the intro. I think the Affordable Care Act prompted mass confusion and concern about what my provider group strategy is going to look like. And we saw it with the Pioneer ACOs. We've seen several revisions to the process, and now we're seeing new models that are iterations of how this all started, this whole move from volume to value. Everyone seems to agree on the movement. I don't run across providers at the large system level or at the small level that don't think there is a movement that direction. I think the question is, what do I do about it, and then when? We used to use the analogy of a foot in two canoes, and we're still very much incentivized around our fee-for-service business. At what point we want to get a foot in the other canoe of value, but at what point are we going to actually be ready to leave that fee-for-service? And we're not there. And back in 2010, when I was helping organizations set up ACOs and prepare for the idea that someone might have a quality program they want to reimburse them around, the concern was, but how much are we going to embrace that? And then how much value are we going to get out of it? And groups, big and small, spent a lot of money on what I would call a defensive strategy. So there's an element of this that is be prepared so that you don't get taken advantage of when something comes around. Yeah. Well, this is it coming around.
Yeah.
And so you'll see CMS test something, as you alluded to, being kind of the market leader in this area. And then the next thing you know, it's coming from other commercial payers or employers. A lot of hospitals are self-funded, and so that's a great testing ground for value-based care strategy as well. So to answer your question, I think that most groups know they need to do something. There's a lot of confusion about what to do, and in my experience, there's no silver bullet recommendation. Everyone doesn't need to be an ACO. Everyone doesn't need to participate actively in the different types of reimbursement. Some organizations are more prepared for pay for performance. Some are ready for shared savings. A lot, as we saw with the Pioneer ACOs, weren't as ready as they thought. And even if you get some return, it might not be worth the investment. So I think the recommendation here is get your data right, understand the rules of the game you're signing up to play and why it would be attractive. A lot of health systems use this as a physician alignment strategy, not just as a reimbursement strategy. And that can be equally as important sometimes. So,
well, that you brought up a number of things there that I think I want to drill down on. I want to come back to the data question in just a second because, and Mac, you and I have talked about this many times about the critical role data plays and reporting plays in this. So I want to come back to that. But I also wanted to ask you, and you started to allude his in your comment, but is the push from the health system side and the hospital side driving a lot of this activity, or is it truly coming from both angles, do you think? Meaning, are the groups up there saying, yeah, we're going to do something, or is it kind of like, oh, we're going to respond to, our the system we're aligned with, some of the things they're developing, and maybe we'll participate that way, and that'll be our solution for now?
Yeah, I think that part of the in vogue mentality has dissipated over time. So I think back in 2010, everyone needed to be talking and marketing their value-based care, their ACO strategy. And I saw in a lot of markets, it was a competitive strategy as much as anything. Now, I think it's more based around the alignment competition. And it was then too, but as an independent group of providers who maybe can't or don't have the resources to invest in their own ACO or their own P4P program, can't put the analytic platform together, it's helpful to align with some sort of network that can. Clinically integrated networks have been a vehicle that has been very effective in this way, aligning both employed physicians and independent practices around a similar set of quality initiatives to care for population. So I think as we move forward, the strategic implication of why a health system would or wouldn't is going to be more of a cost question. And the expense side is where I think a lot of the pinch is coming. So we used to develop quality programs and take them to the payers because they didn't have any yet. And so you could say, we're going to track these 30 initiatives and we want to renegotiate rates based around that. It's a novel idea here. Now payers have a P4P program. They have a shared savings program, commercial and CMS. And so as you as a system are considering this, you have to think, well, how much money is it going to cost me to develop a network, track the quality, report the quality? And if we're not already doing that, then when we start reporting it, if we're already on the hook for the performance, we may take an additional ding on what we've already done. So that cost management side is both the carrot and the stick, I think, in that regard. Yeah,
I know, Mac, you've talked numerous times about the cost accounting role that plays into this discussion and being able to do that, as well as on the shared savings side. I know you have experience going back to your previous health system that you were affiliated with.
Yeah, I think it's interesting if you go back again 8 years or so, and particularly 5 years or so since the time I started with Coker, I think, yes, there are some health systems out there that have really driven this, that have tried to embrace it, get way out in front of it. Most of those are health systems that have their own health plans, the Geisingers of the world, the Intermountain Healthcares of the world. But the average community hospital, the one that Coker Group does the majority of our work with, have really not embraced this. And in fact, many of our clients have said, oh my gosh, please somebody come and save us from this before it actually comes to pass. What has happened, though, over that 5 to 8 years is that CMS has been kind of inexorably, slowly, as they usually are, methodically rolling out their value-based programs, whether that's MACRA or bundled payments. In the meantime, commercial payers have, as they usually do, followed CMS. And so you've got Aetna, you've got United Healthcare, you've got Blue Cross Blue Shield with a lot of bundled payment programs. You've got all kinds of value-based movement on the commercial side, and now CMS. And so I think, and again, I've been saying this for 5 years, so why would I be right now? And I haven't been right for the last 5 years, but I think we're close to the tipping point. Somebody a lot smarter than me once predicted that when the average health systems business is 40% or more value-based, it will then be worth it to them to take one foot out of one of those boats and jump into one boat with both feet. Whether that's true or not, I don't know, but I think more and more health systems, especially with their employed physician networks, starting in January of 2009, are going to say, we can't just dabble in this anymore. We've got to do this and do it right, or we're really going to be left behind.
And as was true in 2010 and is still true today, CMS is notorious for first hanging the carrot, then following with the stick. And so we've already seen in some cases the initial push to get the data and get people reporting and have some information to base this on. Let's test it out. A lot of these market leaders and thought leaders were ready to be the guinea pigs. And then we tested the data and realized that behavior hadn't changed a whole lot. And so we tracked the data for a little while. And now that it's time to we didn't get enough upside to pay for the cost of starting it. Right. And now those same organizations are starting to see the stick come around behind it of, well, now if we don't meet it, we're actually getting additionally penalized for this cost. And I think I completely agree that there has to be a tipping point. I don't know at what point that'll reach the community hospitals like it will reach, the national players and large health systems. But the overwhelming option of who do we do it with, and everyone's got a different flavor of pay for performance or shared savings. And if I'm community hospital that has never dabbled in this and doesn't have a strategy around it, it could be overwhelming to decide who you would work with on it, and then how much of it you can stomach and where you can be successful. And so for that reason, I do think it's important to have a strategy around it, even if your strategy is to wait and wait until it comes to your front door. That can be appropriate in some places, but it's important to at least know what you're dealing with.
What about, you talked about the carrot and the stick that CMS is notoriously kind of known for in the past. The other thing they're really notoriously known for is changing or lack of consistency, let's say. And I have heard that from the hospital and health system side, that it doesn't pay to be bleeding edge in healthcare. It doesn't even always pay to be leading edge in healthcare. And that's, very counterintuitive to what we see in other industries and sectors. Do you feel like we've gotten past that in terms of that kind of mentality? Or are we still, who knows what CMS is going to do come January 1?
I really don't think we have gotten past that. I kind of liken it to the Lucy and Charlie Brown in the football. CMS comes out and everybody's got to be in an APM, and the most common type of APM is ACOs. And then here, 3 weeks ago, they say, okay, well, we're changing the whole ACO model, and we're going to push you all towards risk-based ACOs much, much faster than we thought. CMS came out with bundled payments, in fact, mandated bundled payments around total joints. And then they said, well, maybe that's not something we really want to push people towards. So they held that down for a while. Now they've come out with 31 new bundles through the BPCI advanced program. So it is a very uncertain time, and I have a lot of sympathy for providers, especially providers in the community hospitals out there that are struggling to survive on low single-digit margins, that are saying, look, before I really pull the cord and jump into this, I want to know that the payers are serious. I can say all I want. I don't think this is going to go away, but who knows? It's a very uncertain time. A lot of different signals out there.
Yeah,
and some of it you can take on regardless of whether you participate, right? So for some of those that say, I don't want to be cutting edge, I don't need to be a market leader, and I'll participate only when the carrot arrives, or only when the stick arrives. I don't disagree with that strategy in certain environments, but starting to track your own quality data test it on your self-employed population, whatever it may be. Those are things you can do so that when it comes, you're a little more prepared or knowledgeable about where you could be effective. You can mock up a program just like you would actively participate and track it on your own and test to see how successful you might be and whether or not it's worth the investment.
Well, I think that's a great segue, because I want to talk about getting prepared. And that can mean different things to every different organization, every different leadership team out there, different markets. I think we would all agree the consensus is there needs to be some preparation and a strategy. And so I like using your example, Brandt, when you talked about one of the ideas was we developed a model and took it to the payers. And then the payers adopted that and probably applied it elsewhere and had their own kind of programs where they could offer that. And I think I've seen that too. And I think that that's helped spur more the expansion evolution of this. But there are still those that are, we're going to wait on the sidelines. And yeah, if that is the decision, then there's still preparation, I guess, that needs to happen. So just talk about, different organizations and we can even break them down if you want. But to Mac, your point, a lot of what we're working with are going to be your community hospitals, your rural facilities, or your community health systems in non-urban markets. Those types of facilities and entities can be in very different scenarios than your large urban based or your national base, obviously your for-profits, those types of things. And then the large groups as well, because I think there is a lot of going on there that they could spark and drive a lot of the activity. So, I mean, if we're thinking preparation, where do we start?
So, again, I don't think every hospital in the country needs to try to become a Geisinger, meaning that every health system like those two and others that have succeeded in developing their own health plans, their own value-based population health management programs, for every one that's succeeded, there's 20 that failed. I am not saying by any means that every community hospital in the country needs to jump into being a provider/payer. What I am saying, though, and I totally agree with Brandt, is that unless you're a community hospital out there that doesn't employ any physicians and no commercial payers have come to you with any hint that they're moving toward any value-based plans in the future, you need to be doing a few basic things. And that's really what I kind of wanted to get across in this paper that I wrote recently and in this podcast today. What are those basic things that you should be doing? To me, it boils down to looking at your provider relationships, seeing how your providers are performing, to include the hospital itself, but the employed providers as well, seeing what you've historically done well in things like PQRS or modifier program, meaningful use, etc., seeing where you're not doing so well, and playing to your strengths so that you can start to systematically move the dial on those areas where you know you're going to need to improve as more and more reimbursement becomes dependent on performance. Yeah. It doesn't need to be, again, taking on a huge population for risk-based healthcare delivery. It can be, again, as simple as, on PQRS, we reported our diabetic management metrics, and, we don't really do too well on that, but we certainly take care of a lot of diabetic patients. What can we do? What are some initiatives that we can do that would improve that as that becomes more and more important to our revenue stream?
Yeah, and I think the first thing that comes to my mind is just building block of data, right? So most organizations have some kind of quality metrics that they're tracking and following. I think even independent groups are doing that. But start with data, look at what others are tracking and following, how much of that are we doing, and determine on the key measures, which have been pretty consistent over time. Even since we started this, the targets might change and the objectives and what to do with them and the messaging might change, but it's still a pretty core set of quality components that are important, that are going to drive change. And then, starting to process that internally and look at it. And a lot of that, that's easy to say here. A lot of organizations struggle with resources to have analytics. And that's, a key thing we find ourselves helping with is just putting usable data into usable platforms and information. But I think that's kind of step one in my mind, is having data that you can review and then start to use that to have a discussion with your providers and form opinions about where you're strong and where you're weak.
And, to even get a little bit more specific, I totally agree with you, Brandt. I mean, 10, 15 years ago, when all this kind of was getting started, the average provider group would say, well, I don't even know where to start. I mean, how do you even measure quality? What are some...
It was almost a scary term because, they started thinking, oh, you're going to measure it on outcomes. Well, that's right. A slippery slope and all that. Yeah.
But now, if you're a provider group out there, it's not a real mystery where you really should focus your efforts. So in the quality realm, I would really, really look at how well you're managing chronic disease. Chronic disease, most of us think hospital-centric, and we think that the big ticket items in healthcare are open hearts and total joint replacements and back surgery. But the truth of the matter is the money is in chronic disease management, and the quality and the effect of life expectancy and population health in terms of how well you manage your diabetics and your heart failure patients and your COPD patients and your hypertensive patients. That's really where you need to put your efforts. On the cost front, again, chronic disease management, but also looking at this other big trend that's happened over the last 10, 15 years, which is the move from inpatient to ambulatory. And how can you get on board with that so that you can cut down on those really high-cost readmissions, admissions, inappropriate use of the emergency department, and build a system that, again, is more high quality but also cost efficient because it's got ambulatory services that really provide the access and the care that you need. And it's not really rocket science. It's kind of looking around and saying, well, where do we start? Let's start with diabetic patients and trying to keep heart failure patients from being readmitted to the hospital after they're discharged within 30 days.
Well, I hate to put it this way, but there is a lot of low-hanging fruit when it comes to optimization and efficiency, right? I remember the same thing. You talk about the data in terms of doing something with it is kind of like the data's there, I think, in most cases. There's a lot of really good data now, particularly even at the small health systems or private groups. It's being tracked. It's just, okay, what do we do with it? How do we make it meaningful, I guess? And that is a whole nother layer, I think. But there is a lot of kind of basic things.
Yeah, I think that getting the basics down and having a better introspective look at what you're doing around quality. And I totally agree about the chronic disease management, those being the key drivers. But ultimately, the challenges that we saw in trying to implement strategy around this is you can stand up a network, you can track quality data, and you can report things, whether you have a relationship contractually with payers or not. But getting providers to change behavior and then having an effective support structure around that. So not just preventing readmissions, but then what do you do with the patient? Who's going to know that? Who's going to make the call? We've seen care coordinators employed across the country and then fired across the country because it was too expensive and we weren't sure what the value was. And so I think that piece of, call it an MSO, a pop health MSO of sorts, which, can be big or small depending on the network size and that sort of thing. But that's a key piece of how you make this effective over time. But you don't have to have all that to start getting a sense for your quality indicators. As Max said, that used to be gray area, and now those are at least pretty specific, give or take a few on the perimeter. They're 30 to 40 core quality metrics that most organizations have at their fingertips. What they do with it is a big variable.
The other thing I'd say there, too, is that, I know you've had podcasts on this, Mark, and it's certainly something CwC does a lot of. But if you're a hospital organization out there and you have not incorporated some sort of what I call value-based compensation for your physician providers, you better do that. Because as you mentioned, Brandt, there are providers out there that are going to do this because it's the quote-unquote right thing to do. But for the vast majority of them, believe me, you're going to have to change the incentives. And you don't have to start crazy and say, everything's value-based and we're going to totally get away from production-based metric. But you certainly have to start incorporating.
Yeah, I couldn't agree more. And I've seen a lot of organizations, even recently, who have adopted that mentality, make the mistake of, you're right, we got to really tie physician comp to this. All our primary care docs are going to be 50% based on quality. Well, that's great, but your orthopedist and your cardiologist aren't incentivized around the same circle of trust there. And so it doesn't end up driving change. It just doesn't. Point. You have less visits in primary care and you have more nursing staff to take care to keep people from coming in for their visits, and that's about it.
And the other thing there is, they are so many on the health system side are so kind of leaning towards RVUs just because it's something we know pretty well, right? I mean, it's something that's very tangible, quantifiable, that everyone can somewhat relate to, and it more or less puts people on a similar plane in terms of apples to apples. When you add quality in there, I agree. A lot of them are like want to jump into the deep end head first on it, but they're not prepared necessarily with either the metrics that they're using or the ability to truly track and report on those metrics, or like you said, the consistency across specialties or their kind of provider population. Or, you have these situations where it's just something that is a non-starter when they bring up to the medical staff, and it's just scary still, I guess. And so that's why we see a lot of the majority of the comp plans are still production based. Maybe 10% ish of total comp is going to tie back to quality.
And it's hard because a lot of the organizations we're talking about here in the mid-size and rural don't employ all of the specialties. And so they might not have true comp control of that. It might be PSA arrangement. It might just be a loose affiliation or a preferred referral network.
Yeah.
So that makes it even harder to incentivize around all of that, particularly if it's a competitive market. And that's part of the reason that the Geisinger, Dignity Health of the world have been successful with some of this, is because they have a large network, comprehensive network of providers for which they control the incentive.
And maybe I'm being overly optimistic here, looking at the glasses being half full. But I think the other good thing is we're at a point in time where not only is the CMS, for example, offering more compensation based on performance, but they are also setting up new revenue streams that incorporate things that doctors like myself 5 years ago, 10 years ago, certainly 20 years ago, wouldn't have dreamed that we'd get paid for. So chronic care management telephonically on a monthly basis, annual wellness visits, transitional care management, end-of-life care. I mean, those are things that are good, sound, basic things for patient care. and need to be reimbursed. And so you can really get a twofer in that you can drive your performance up by doing those things, and you can garner a new revenue stream. So,
well, and taking that kind of even one step further here as an example of how this is driving change, it's even driving change in clinical behavior and activities. And you alluded to it, Mac, but I'd take it even further and to talk about all the technology out there that has emerged that allows for this to take place. I mean, now, if you just look at telehealth, for instance, and we don't have to go down that whole rabbit trail, but if you just look at that, that's one of the areas that, we know there are codes that can get reimbursed for now. It's becoming widely accepted and even embraced by patients. And it's something that the technology, meaning the technical aspects of it, is there. It's more about kind of change management and adapting to that from a behavior standpoint. You think we're only going to see more of that, or in terms of the technology, or what role will it play?
Oh, I think it's huge. And my passion is actual care process design that incorporates those kind of innovations. And, you can't, I don't know what's a good metaphor. You really can't drive in the Indianapolis 500 with a Model T. I mean, you've got to change the way that medicine is practiced at the bedside, at the exam room, in the OR. Is that easy? Are those habits hard to break? Are providers difficult to steer into a new direction? Yes, they are. But again, change is inevitable, and it's going to happen, I think, fairly quickly, and again, inevitably. I don't think you can stick your head in the sand and say, we're going to continue to use leeches and bloodletting for medical practice.
Maybe in some places.
Well, and if there ever was a secret about it, it's out. It's broken. Everything's very broken, and now everyone knows it. We know how much we're spending on it. And so the impetus for change is there, even though providers and systems don't want to admit it or might want to hang on until they don't need to see patients anymore themselves. We can't continue to ignore it now that we understand the gravity.
One of the things I do like about the direction that seems like we're going, or that we've come in just the last couple years even, is I feel like we're getting closer to some degree of balance, or at least the accepting notion that balance is needed in terms of connecting or linking quality and cost, or the quality piece and the economic piece, right? Mm-hmm. No provider out there really wants to look at this solely from a cost and financial standpoint. But the reality is you have to. That's a factor. Whether you're talking about commercial payers or CMS or anything in between. But I feel like we're getting to that point where we can link the two a little bit better. So I don't know, maybe we kind of bring this full circle. I know one of the things, Mac, you talked about in the paper, first of all, we know there's going to be a financial impact as of January 1, 2019. That's real. That's something that is directly quantifiable. Going beyond that, though, what are some of the other kind of quality and cost initiatives that are kind of alternatives or options to help optimize and prepare for what's coming?
So I think it's important, as you and I have talked before, Mark. I'm a big picture guy, and I think it's important sometimes to step back from all these details that we talk about with these programs and say, what is the overarching imperative that is driving this? And to me, it's very clear. The IOM came out with their report in 1999 saying 2 air is human. 90 to 100,000 people are harmed every year, if not killed, in hospitals due to medical errors. And really not too much change after that. Quality got a little bit more attention, but quite honestly, I think most of us said, well, that was probably spurious, and Not sure we believe that. Then you get to 2010 with the passage of the ACA, and everybody said, the inflationary curve of healthcare is untenable. We have got to get a hold of that. So things like ACOs were put into place. Things like the sustainable growth rate were put into place. Mm-hmm. That didn't work. So then along comes MACRA. So now, again, the overarching imperative is how do you simultaneously drive up quality and drive down cost? The value equation describes that quite well, where value equals quality over cost. And the neat thing about healthcare, I've always said, is that in most cases, quality is inversely related to cost in the healthcare industry. So if you go buy a television set and it's got 1,000 pixels per square inch and gets 999 channels and has surround sound, that quality is likely to cost you a whole bunch more. But if you go buy a cholecystectomy or a heart attack in a hospital, that quality is likely to cost you a whole bunch less because it means less complications, shorter lengths of stay, more efficient use of resources, appropriate pharmaceutical care, etc. It's a neat kind of and somewhat unique aspect of healthcare that the more quality you get, usually the more costs go down. So it's incumbent on us as providers and consultants to say, well, again, where do you start doing that? Where do you take your highest cost, your lowest quality, and start to try to push that in the opposite
direction? I completely agree. And I think that we often focus on the expense side with this. Sure. How do we drive down the cost? Everything's too expensive. But to a lot of groups out there at the more granular operation level, it's also about the revenue, right? And so we can drive down costs a lot, but if our revenue is dipping at a more increased rate, then we can reduce costs all day and we're not going to be any more financially. Mm-hmm. So I think there has to be, and that's where that, not to overuse the carrot and stick analogy, that's where there has to be some sort of incentive, not just for a doctor to make a different decision at the bedside, but for a system or for a group of providers or for the patient to make different choices about how they seek, administer, and ultimately pay for the care.
Yeah, no, that's right. I mean, I think it also whether it's the carrot or the stick, something to make it meaningful, because a lot of this stuff that we're talking about doing from a behavior standpoint is stuff that could have been done at any point. I mean, there's some like new contracting models mm-hmm. and risk-based contract, things like that. But a lot of the stuff from an efficiency standpoint is more about optimization, optimizing what's already there, as opposed to necessarily just completely changing behavior. And then I think there are those things, Brandt, to your point, that do change or alter behavior a little bit and in a positive way and allow you to kind of both enhance revenue and as a result optimize margin. And I think that's something that I think at first I remember when the ACOs first came out and it was kind of like, well, it's just kind of capitation on steroids. I heard that a lot. Or we're going back to capitation or whatever. And I always said that's not the direction we want to take this. If nothing else, in concept, we don't necessarily want that because there's a very kind of limited upside to capitation to a certain degree. I mean, there's a ceiling on it. I'm not saying there's zero upside, but right, there are limits. Whereas I think, Mac, to your point, and the quality equation and how that formula works, really that breaks down a lot of those potential limitations. Meaning the higher we can improve quality and the further we can take that, then the value.
Well, I think there's so many features of healthcare that, again, make it an advantageous time to try to do this. Number one, there's that inverse relationship between quality and cost that I just talked about. Number two, there is immense waste. Right. I mean, again, a lot smarter people than I have looked at this, And I don't know if it's 20%, I don't know if it's 30%, I don't know if it's 50%, which some people say, but even if it's 10%, 10% of $3.4 trillion is a lot of money.
Yeah.
And so, you get at some of that waste, and I'll readily agree that we can't get at all of it, but you get at a small amount of that waste, and a lot of those costs go down. The other advantage we have right now, as you mentioned, and I won't go down the rabbit hole either, but we've got technology that we didn't have in the 80s or 90s when we tried this the first go around, that allow you to do things, number one, measure your performance, and that's huge. The old adage, you can't change what you don't measure. And so we can measure now in pretty real-time fashion, quality and cost, and know how we're performing. And two, the technology to allow for innovative care delivery that, we never had before. And very much probably improved care delivery and at much less.
Well, as we bring it full circle and closing comments, I think I don't want to end the conversation without at least getting a little bit of both of y'all's perspective on clients we work with or some organization coming to us and asking, what do we need to be doing right now? And obviously that's going to mean different things depending on where they're at. But let's just assume they're not doing anything, but they're also not on the leading edge of innovation either. And yeah, it was probably going to be more of those community health systems, maybe large groups, something like that. But in terms of where we kind of would start with attacking that question, what are y'all's thoughts?
Well, in this paper that I wrote, I actually outlined a very step-by-step approach. And certainly I don't mean to say that the approach needs to be the same for everybody, but these are basics. These are not, cutting edge, leading edge, certainly bleeding edge type things. These are basic things that I think everybody should do. Number one, they should know how they performed in the past. So if you were in PQRS, if you were in the Value Payment Modifier Program, go pull your QRUR report and look at that and see how you performed in those areas. If you reported data for 2017 for MIPS, go pull that and see how you look. And use those things as a roadmap to see where you need to improve and where you're going to focus your energy. Pick off one or two areas. By the way, you can use those to get credit in the CPIA category of MIPS by putting in care process improvement initiatives in those areas, and set those up and start somewhere. You don't have to start big. You don't have to boil the ocean, but start somewhere and try to move the dial in areas that are very important to your specific organization. Get your providers organized. You don't have to be a level 18 ACO, but you might want to start a clinically integrated network, even just with your own employed physicians, so that, again, you're systematically measuring performance, feeding that back to the providers, and if they're your employees, putting some of their compensation at risk for performance on those metrics. That's called alignment. It's not all that challenging to do. And so those are really kind of blocking and tackling. I think there's probably the rare organization out there and somewhere that doesn't need to do that, but they're few and far between.
Yeah, and I think even stepping away from the very practical checklist that we can help walk through depending on the organization is just take inventory of what you have and what you've done and identify the relevant factors in your market, put them on paper, engage your providers, not just when it's time to track quality metrics, but engage them in the process of putting this together. everywhere I've worked, there have always been providers that are interested in this, and it's not always the CMO, but there are people who care and are willing to, in many cases, donate time, which is a shortage on most providers to begin with, to work on this and make it a valuable part of how their system or their group delivers care. So I think starting with that and starting the dialogue so that you can then ultimately work towards a plan. And I think the plan is where it could be highly variable depending on your circumstances. But, you got to kick your own tires first to figure out where you stand before you can start making any kind of decision.
That's right. Yeah, you got to know the baseline or establish a baseline and know what resources you have, and then you can kind of roadmap from there. And I agree, Mac, too. You don't have to do it all at once, or doing this in a overtime phased approach where you lay out the priorities and milestones is something that is doable, and it really is doable for any size organization, pretty much any scenario, and it's going to get to that point where it's critical, and meaning it's a must have, and even if we're still in that point where it'd be nice to do, this is the time to kind of get ahead of that curve. This has been extremely helpful, and again, Mac, I really appreciate the paper and other things where you've written on this topic and presented on it. And so we'll make sure, again, that information is available and where to find Mac and Brandt. But great conversation, guys. I look forward to the next conversation that we have. I'm sure there'll be plenty more on this topic, particularly as we get towards the end of the year and further into 19. See how it plays out. But thanks for joining us, and look forward to the next one.
Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.